Hey guys, I think it's time to start again. So we left off, we were talking about osteoporosis, and I said we're going to talk about a couple of terms that we're going to define just again, so get everybody's on the same basic home page to begin with. So what is osteoporosis? You probably already kind of know. I'm sure you're a little bit familiar with that term. So osteoporosis is an overall or generalized decrease in bone mass. So if you would take out the dog femur and you weigh it, and it weighs, 1,000 grams or whatever it is, dogs that would have osteoporosis, you would take out the femur, it would look the same, but it might weigh 800 grams. So the amount of bone is less. The bone mass is less in dogs that have osteoporosis. Okay. The composition of the bone is normal. Okay. So the amount of calcium in it, the amount of phosphorus in it, whatever minerals other than that are in bone, it's all the same, but there's just not enough of it. Okay. Osteoporosis in dogs and people can be caused by lots of different things. One of them is Cushing's disease, hyperadrenal corticism. One of them is hyperparathyroidism, senile osteoporosis, old cats, old dogs. Sometimes their bones become just like old people. They become weaker, they become thin. And that's just due to osteoporosis. So radiographically, Röntgen signs, we just see cortical thinning of the bone. That dog that in the last part of the neurology lecture that had hyperparathyroidism, it had kind of eggshell-like mineralization around the vertebral bodies, if you remember that. You could barely see the mandibles, the cortical bone of the mandible. It's not like thick, very white, radiopaque bone. It's really thin. That would be an example of osteoporosis. Okay. This is a slide, a photomicrograph of a normal bone here. We got these cancellous bones, so we got these little holes in it. This is a dog with osteoporosis. So the bone itself looks the same. It's just there's not as much of it. Okay. Another term called osteomalacia, and this is really rare to see this in animals, especially nowadays in developed countries where you're feeding dogs good diets and things like that. But osteomalacia typically means soft bone. So it's pliable bone that's kind of rubbery in appearance. It's not really as hard and as compact as it should be. So in this condition, if you would weigh the bone is going to weigh the same for normal bone and osteomalacic bone, which is different than osteoporosis. But the content of the bone is different. Okay, you don't have enough calcium in the bone, and so the bone is softer, but it still weighs the same. Okay. And osteomalacia can be caused sometimes with chronic renal disease or some malabsorption problems or vitamin D issues or calcium deficiencies. A lot of times, and again, we hardly ever see osteomalacia nowadays, at least in this country, in dogs and cats. And sometimes you'll see it in wildlife if the owners don't know how to nutritionally support the wildlife, or in birds and things like that. So we can see some osteomalacia, but it's pretty rare. This is an example. This is a human femur. So again, it's just kind of crooked in here. He's got some other issues in previous surgery. But anyway, that's caused by osteomalacia, kind of round or kind of bendable, not as hard bones. Osteopenia is another term. I generally use osteopenia as the same as osteoporosis. Okay, so it's kind of synonymous with osteoporosis. It just means a diffuse lack of the amount of bone. Osteosclerosis is another term that is the opposite of osteoporosis or osteopenia. Osteosclerosis is too much bone. Okay. And another word that is the same and synonymous with osteosclerosis is osteopetrosis. All of these are, weird words, but that means the same. So this is the opposite of osteoporosis. It's an overall increase in bone mass. Typically, the only time you will see osteosclerosis is in cats and in birds, which is kind of weird when you think about it. I've seen osteosclerosis in cats several times where the vertebral bodies are so dense they look like pieces of chalk. Okay. Or the long bones are so dense they hardly have a marrow cavity at all. It's just like one big thick stick. Okay. And it happens in cats. And a lot of times in cats, we never know why it happens. The calcium phosphorus levels are normal. We don't know why it happens, and they don't show any clinical signs. So most of the time in cats, we think it's probably incidental. And you'll also see it in birds. And the weird thing about it in birds, A lot of times you'll see it in the long bones of the bird. So sometimes, most commonly in the femurs and the tibial tarsal metatarsal bones of birds, sometimes in the wings, but most of the time in the rear limbs. And the weird thing about it in birds is anytime you see it, it happens all the time in birds. And anytime you see it, it will only happen in female birds. And it's due to stuff about birds that I don't understand. So it has to do with female birds and egg laying. And if they don't, they're making all this calcium that's supposed to go in eggs, but if they're not making eggs, they got to stick the calcium somewhere. So it ends up in their long bones. And it's called osteopetrosis in birds. Okay. But the weird thing in birds is you can bet your bottom dollar if you see osteopetrosis or osteosclerosis of bird legs, it's a female because it doesn't happen in males. Okay, so here's this cat. Look at this. Look how opaque the femurs are. Very thin areas of medullary cavity, opaque pelvis. Look at again, the ribs are super opaque. The vertebral bodies are super opaque. They look like little pieces of chalk almost, hardly any. Normally you see kind of cortical bone around it and a marrow cavity in the middle. Here you really don't, okay? But why that happens, I don't know. And here's a female bird. So here's the femur, here's the tibial tarsal bones, but there's increased opacity in the femurs here and here. And so that is, the only thing I can tell you is that's a female bird. Okay, moving on, we're going to talk now about focal or regional bone loss. And again, we said early on, I think the first slide of this section is that it takes 30 to 50% of the bone to be gone before you're really going to see it definitively on x-rays or radiographs. Okay, so again, it takes a while, and again, it takes a long time. So sometimes it may take up to 10 to 14 days before you're going to see the bone loss. So it can cause diffuse osteoporosis, especially. It's going to take a while to see it, and you may not see it early on at all. It takes a lot of the bone to go away before you're actually going to see it. Geographic bone loss is loss of bone, not entirely all over the skeleton, but just in a focal area, like in the distal aspect of the femur, maybe, or the distal aspect of the radius, or something like that. It is usually more common to be caused by a focal lytic lesion, like a tumor or an infection of that part of the bone. It may be expansile, but it's usually due to something aggressive happening in that part of the bone. Again, 50%, 30 to 50% of the bone has to be gone before you see it, but depending on how aggressive it is, you may see it earlier than you would with diffuse osteoporosis. And then we get another type of bone loss that you'll see radiographically. It's not horrifically obvious, but it's called permeative or punctate bony lysis of the bone. I'll show you an example of that. And this is where you have a part of the bone that has just little, very small, lucent stippling or little bitty holes inside that bone that cause it to look like it's permeative. Okay, so here is an example of permeative lysis. This has a periosteal action, but you can see there's these little areas inside the bone that you can see up in here, kind of this little lucent areas. It looks like kind of ill-defined bony lysis inside that type of bone. Here's probably a better example. If you look here in the proximal humerus, you can see all these little focal areas of bony lysis inside. There's a bigger one here, but all these little focal areas, this is more normal appearing bone, okay? And so this is a type of permeative type bone lysis. You can also see lysis of the cortical bone. Look at this nice, thin, well-defined cortical bone that's normal down in here and here. But if I go proximally, it becomes really thin here and super thin up here. And that's because that cortical bone is starting to be lytic, it's starting to be eaten away. And if you look real close, right up in here, we're starting to see a little periosteal reaction here. That's kind of a smoothly marginated periosteal reaction that's in that part of the bone that we're starting to see here. Give that time, and that's going to become more lytic too. Okay, then we have to talk about bone parts, names of bone parts of the long bones especially, and growth plates. Okay, so let's think of a long bone. So what's some examples of long bone in a dog? Well, it'd be the radius, the ulna, the humerus, the femur, the tibia, and the fibula. Those are your big long bones. Okay, and all of those long bones have different parts. Okay, so the shaft of a long bone right in here is called the diaphysis. Okay, let me just go ahead and uncover all these up. So the diaphysis of the bone is the long mid portion of a long bone. That's called the diaphysis. Okay, these terms you need to know. Okay. At the either end of a long bone where it kind of flares out, but proximal to the growth plate, is called the metaphysis. Okay, so that is the expansile flaring out of the distal end or proximal end of a long bone. Okay, the growth plate itself is this well-defined line here, and you can see it here a little bit of this ulna that's starting to close already, but that's the growth plate. The real word for a growth plate is called the physis. Okay, and the distal end of a long bone, the part that is adjacent to the joint itself, that's distal or proximal to the physis, is called the epiphysis. Okay, so those terms you need to know, and you need to know where in the bone those are located. So again, diaphysis is the big long shaft of the bone. Where it flares out on either end is the metaphysis. Then you have the growth plate itself, which is the physis, and the distal end of the, or proximal end of the long bones is called the epiphysis. That's the part that's next to the joint. Okay, growth plate injuries. If you have a young dog or young cat, usually less than about a year of age, and they damage their growth plate by trauma, they hit it on something or fracture or something like that, that can lead to growth abnormalities, which leads to what's called angular limb deformities. So the bone doesn't grow in a normal way. It may stop growing at all, or it may grow off to one side, okay, abnormally. Okay, so growth plate injuries occur in any animal that's not skeletally mature. So less than a year of age, animals can undergo growth plate injuries. If you don't do something about them surgically, a lot of times to fix these growth plate injuries, a lot of times the animal over time, as it heals, will heal in an abnormal position, resulting in an angular limb deformity. Okay. Now, these you need to know too, and there's no easy way to learn these other than you just have to commit them to memory. This classification is called the Salter-Harris classification of growth plate fractures. And it comes from the human medicine, but people in veterinary medicine use the same thing and it works well. Okay. So here is the distal end of a long bone. So here's the diaphysis right up in here. Here's the metaphysis. This is the growth plate. This is the epiphyseal portion of the bone, or the epiphysis. Okay. If you have a fracture in that distal end of the bone that goes straight through the growth plate, and now you have displacement of the epiphyseal portion of the bone, that is a Salter-Harris type 1 fracture. Okay. A fracture that goes straight through the growth plate is a Salter-Harris type 1 fracture. Okay. The prognosis for a Salter-Harris type 1 fracture, if you don't fix it, it's poor. The animal is going to develop really bad arthritis and an angular limb deformity. But if surgically you go in and you can fix it, the prognosis for continued normal growth is usually pretty good. A Salter-Harris type 2 fracture is a fracture that goes through the growth plate, but then exits through the metaphyseal region of the bone. That is a Salter-Harris type 2 fracture. The prognosis for a Salter-Harris type 2 fracture is also pretty good if you fix it. If you don't fix it, it's going to be poor. Okay, so Salter-Harris type 2 goes through the growth plate but exits the metaphyseal region of the bone. Okay, a Salter-Harris type 2 fracture, just like it says right here, of all of the Salter-Harris fractures, this by far is the most common one that you're going to see clinically. That you should probably know too. Salter-Harris type 2, what it is, and it's the most common one. A Salter-Harris type 3 fracture is a fracture that goes through the growth plate but exits the epiphysis. Okay, and you notice if by definition of it exits through the epiphysis, what's on the other end of the epiphyseal portion of the bone is the joint space. So this is an articular fracture, a fracture that involves the joint space itself. Anytime you have any fracture that involves the joint space, the prognosis is not going to be as good. Okay, so the prognosis for a Salter type 3 fracture, even if repaired, is going to be fair. And by that means that it's probably going to heal, but they may develop osteoarthritis and they may develop an angular limb deformity. A Salter-Harris type 4 fracture is one that goes through the growth plate, but exits both the metaphyseal region and the epiphysis. Okay. And again, this is an articular fracture by definition. And so the prognosis for these, even if you fix them, is going to be relatively poor. The last Salter-Harris type fracture is very similar to a 1. It goes just through the growth plate, but now we have such trauma that it actually grinds the two edges of the fracture together, which destroys the osteogenic properties of that portion of the growth plate, and that bone will continue to not ever grow. Okay, growing just stops. Okay, because of the trauma and grinding of the two fracture fragments together and destroying the growth potential. Okay, so these fractures again will heal, but the bone's not going to grow and it's going to stop growing, which will lead to angular limb deformities because now one radius is growing normally and the other one is not. Okay, so the prognosis for these is also relatively poor. So you need to know what I just told you, what the growth Salter-Harris type 5 fractures are, where the fractures start and end, which ones have good prognosis, which ones have poor prognosis, which one's the most common. Okay, so this is a young dog, and this is I can put this on a test, and this is a fracture would be a Salter-Harris type what? Okay, well, we have a fracture. It looks like it's probably going through the growth plate. It's also exiting the metaphyseal region, and it's also exiting the epiphyseal region. So that would be a Salter-Harris type 4. Okay, keeping on the topic of growth plates, if I look at the radius and ulna, there's obvious growth plates. There's a proximal growth plate of the radius here, that line there. So what would this part of the bone be called? Is that the diaphysis, the metaphysis, or the epiphysis? And the answer obviously is that's the part distal or proximal to the growth plate next to the joint. That is the epiphyseal portion of the bone. This is also the epiphyseal portion of the bone because it's distal to the growth plate. Okay, so if I look at, here's the growth plate or the physis itself. Here's another growth plate on the distal aspect of the radius. Okay, the proximal end of the ulna has a growth plate in a weird spot. It's right here. Okay, and then the distal end of the ulna has a kind of conical shaped growth plate right here. Okay, the thing that you need to know, very commonly, dogs will have trauma when they're young that affects the distal growth plates of these long bones. Trauma to the proximal ones is pretty rare. Okay, but a lot of times they'll damage these growth plates of the distal radius and ulna. And when they damage it, you have to realize that of the radius, 80% of the growth of the radius comes from the distal growth plate. Only 20% comes from this one. Okay, so if I damage the distal growth plate of the radius, which again is pretty common, it's going to severely affect the growth potential of the length of that radius. Okay, and it's even more exaggerated of the ulna. The length of the ulna, 85% of the growth of the ulna comes from the distal growth plate of the ulna. Only a small part comes from the proximal aspect, 15%. Okay, so if I were to, even though it's rare, if I was to damage due to trauma this growth plate here or that one, it's probably not going to have that much effect on the length of the radius and the ulna as the animal grows. If I damage the distal radius and ulnar growth plate, it's going to have a huge impact on the length of those radiuses and that ulna. Okay, then we have to talk about angular limb deformities. So let's go back to this slide. Let's say I damage this growth plate here of that distal radius. And we know that that growth plate is responsible for 80% of the growth. So let's say I damaged it to the point where it stops growing early on. Okay, so then on one side, the radius is going to be really short. On the other side of the animal, the radius is going to be normal. It's going to grow like it normally should. So you're going to have one limb that's shorter than the other. Okay, if I don't damage the adjacent ulna, the ulna next to this damaged radial growth plate will continue to try to grow. But the radius, its counterpart, that normally grows at the same rate, isn't growing. And so that will lead to the bone down in this region and up in here being bowed one way or the other. That's an angular limb deformity because now we have no growth from the distal radius and normal growth from the distal ulna. Some of these dogs, you'll actually do the opposite. You'll damage the distal ulnar growth plate, but the radius is normal and tends to keep growing. Okay, so if that was happening, now let's imagine that we have no more growth from the ulna, but the radius continues to grow. So the radius is going to continue to grow, and it tries to push out this area as it grows, but the ulna is not growing with it. So it has a hard time extending distally because the adjacent ulna is not doing anything. And so that growth has to go somewhere. So it usually will lead to bowing of the radius out like this, because the growth of the radius has to go somewhere, and it's restricted due to the lack of growth of the adjacent ulna. Okay. If the opposite were true and I damaged the distal radial growth plate, but the ulna kept growing, now the ulna can grow bow-caudally and tend to push this portion of the limb cranially. Okay, so you have to kind of think about the mechanics of it. If the premature closure of the distal radial physis stops and the radius stops growing, but the ulna is still growing, which way is that growth of the ulna going to push the limb? And it also affects the elbow joint, usually proximal to that area. Okay, so let's look at this. Is an example of premature closure of the distal ulnar physis, which is the most common one. Okay, so now I have a trauma that caused cessation of growth from the distal ulna, but the radius keeps growing. Okay, so as the radius keeps growing, it's got that length of the bone has to go somewhere. So again, it tends to bow cranially. Okay, it's not straight anymore, it bows cranially. Okay, and because of that, it tends to, as it tries to push out, it will also tend to push the ulna, the proximal end of the ulna where it joins the elbow, out as well. Okay, so I end up with a bone in the ulna due to premature closure of the distal ulnar physis, where the ulna is distally subluxated. It tends to extend further distally than normal, and it leads to an incongruent elbow joint. So we get distal subluxation, so increased joint space between the humerus and the ulna, along with bowing of the radius cranially. Okay, if I get distal closure of the distal radial growth plate, it does the opposite. So now the distal portion of the ulna is growing normally, the radius is not. And so as the ulna continues to grow, now the radius gets pushed out distally, because this is growing, the distal end of the radius is not, but it leads to increased gap or incongruency between the humerus and the radius. Okay, so both of these you will see, and the easy way, this is an example of normal. So here's the easy way to remember what's going to happen. Okay, this is normal. This is a cartoon of a normal elbow. So here I have the ulna here. Okay, this is the radius, and this is the distal, the humeral condyles. This joint is nice and congruent. It's nice and thin and smooth. Okay, the joint between the humerus and the ulna, the humeral ulnar joint, is nice and thin and smooth. Okay, if a dog has distal closure of the radial physis, right here, radial closure, then you get distal subluxation of the humeral radial joint. So radial closure leads to distal subluxation of the humeral radial joint. Premature ulnar closure leads to distal subluxation of the humeral ulnar joint. Okay, so premature closure of the ulna causes distal subluxation of the humeral ulna joint. Premature closure of the distal radius causes distal subluxation of the humeral ulnar joint, as well as bowing of the antebrachial bone. So it will also cause bowing of the humerus and ulna, or of the radius and ulna. Okay. So this is a basset hound, and basset hounds normally have messed up legs because they're basset hounds. Okay, but this one's a little exaggerated. So in this case here, if I look, here's the humerus, here's the proximal end of the radius, this is the ulna. Okay, does it looks like the humeral radial joint space is still nice and congruent. It's right next to each other. But now I have the distal humerus here, and here's the ulna here. It's wedged. It looks like this part of the ulna is being pushed caudally and is distally subluxated. Okay, so because of that, which one would you think this would be causing this angular limb deformity? Premature closure of the distal ulnar physis here, or the distal radial physis? Well, which one's distally subluxated, the ulna or the radius? The answer is the ulna is distally subluxated. So that's due to premature closure of the distal ulnar growth plate. Okay. Another example there. This is an example. Now, which one's subluxated? Now, the ulna is sitting right where it should. That joint between the ulna and the humerus is nice and well defined, but there's increased gap between the distal end of the humerus and the radius. Now we have mild distal subluxation of the humeral radial joint, which is due to distal premature closure of the distal radial physis. So basically, to know which one it is, you're going to look and see what the relation is with the ulna and the radius with the distal end of the humerus. If you diagnose these early on, the surgeons can come in and they can actually fix these, although a lot of the dogs will continue to develop degenerative changes of the elbows. And they fix it by making an on-purpose cut through the ulna. And that will allow this ulna to go back and snap back in the normal anatomic location. And over time, that area will tend to fill in with bone. Okay, fractures. Now we have to talk a little bit about fractures and how to classify them, how to characterize them, and talk about them. Okay, so remember, always take two views, orthogonal views, just like that early on, the first slide, that elbow. You're going to miss things unless you take two orthogonal views at 90 degrees to each other. And anytime you take a radiograph of fracture, let's say you have a fracture in the mid portion, mid diaphyseal portion of the radius, you always want to get the joint above the fracture and include the joint below the fracture in the same radiograph. So if you have a fracture of the mid portion of the radius, you always want to include the elbow and the carpus on both of those 90-degree views. Okay, so here I have an example of fracture. Obviously, there's a fracture here in the distal aspect of the radius, in the diaphyseal portion of the radius, and one of the adjacent ulna. Okay, I can see the fracture here as well. Over here, there's the radius, and there's the ulna. Okay, a fracture, it's not hard to see fractures like this. It's pretty easy. There's malalignment of the bone, everything, it's pretty easy to see that. The fracture obviously results in incongruity of the bone and the cartilage, and probably damage some of the periosteal reaction on top of that area. And he's got some extracapsular soft tissue swelling around that fracture. Okay. Although most fractures, just like that last one, are visible, sometimes they're a little harder to see, and they're usually radiolucent lines. But sometimes if they're very minimally displaced and this part of the radius is just right on top of that part of the ulna, sometimes the fractures actually are more opaque than normal. So instead of a radiolucent line, sometimes it's a very thin radiopaque line due to summation of the two fracture fragments sitting right on top of each other. Okay. But most of the time, they're radiolucent lines. Okay, so fracture, this is a chronic healed fracture, which we're going to talk about how fractures heal in a minute. So here's a chronic fracture of the distal end of the radius. It's got this great big huge callus around it. Similar old fracture involving the distal diaphyseal portion of the ulna, which a callus around it too. So that's a bridging bony callus as that fracture tries to heal. Okay. So some terms that we need to talk about how you describe fractures. This is a fracture. Obviously, it's all these metallic areas in here. This is due to a gunshot. So these are all ballistic fragments from a bullet, and it causing this, this fracture involving the ulna. Okay, the radius next to it is also fractured. But we can see there's multiple fractures. There's a fracture here up near the olecranon. There's a fracture exiting right in here in the caudal cortex of the ulna. There's another fracture right in through here. It's oblique. It's coming all the way through this area, right in this area. It's exiting right here in the distal aspect of the ulna. There's another fracture involving the proximal aspect of the radius. There may be even a fracture in the humeral condyles. I'm going to have to take other views to see. So this is and then you can imagine that if this is an acute gunshot injury, there's probably going to be an entry wound. And so there's a hole in the skin that's leading into the fracture, which is going to be most likely going to be causing an infection going forward. Okay, so an open fracture is a fracture that has communication to the outside world, as in a gunshot wound. Okay, sometimes a fracture is so severe that a piece of the bone will actually stick through the skin. That would also be an open fracture. A closed fracture is a fracture that happens, but the skin surface is intact. There's no communication between the fracture itself and the outside world through penetration through the skin. Okay, an incomplete fracture is one that goes through one cortex only, but doesn't exit through another cortex. Okay, Another name for an incomplete fracture is a green stick fracture, and these happen relatively commonly in animals that are young, so less than about a year of age. And it gets the name green stick as if you would go out and get a tree limb, a thin tree limb or a branch of a tree, and if it's a live tree and growing and you try to break it, you try to bend it and break it, typically it's going to break on one side, but the other side is harder to break. Okay, so it gets the name of a green stick fracture. And again, usually you see these most of the time in young animals going through just one cortex, but doesn't exit out anywhere. Okay, these are really easy. Basically, you put the dog in, a cast or a splint or something like cage confine them, and it'll heal up pretty quickly. Okay, this is a fissure fracture. If I look here, so these got a bunch of fracture fragments up in the proximal end of this tibia. There's another fracture here in the fibula. But if I look, there's a fissure fracture line, this radiolucent line that comes out here, but there's another one going down here. Okay, so that is called a fissure fracture. So that is a fracture line extending distally, or it could extend proximally throughout the rest of the limb. Even though the majority of the fracture exits here, there's still another fracture line. It's kind of like a window crack in your windshield, right? Give that time, put some more stress on it, and it will probably extend and end up coming out somewhere else. So that is a fissure fracture. Okay, a depression or compression fracture usually happens in areas of flat bones. So this is one typically that you're going to see in the region of the skull. This is a CT exam. So this dog got bashed in the head by something. Okay, and so this is the calvarium in here, and there's pieces of calvarium that is not congruent. And this is where something bashed him in the head. And now we have pieces of bone that's probably inside the calvarial vault and likely putting pressure on the brain or causing hemorrhage in that. That's called a depression or a compression fracture. Okay. A complete fracture is the opposite of a green stick fracture. A complete fracture is a fracture that goes through one cortex and exits out the adjacent cortex. So is a fracture completely through the bone. Two cortices are involved. Okay. This is a complete fracture here, but we can also put another word on it. It's transversely oriented. It goes straight through the bone in a transverse orientation. Okay. And so we can call this a transverse complete fracture. Okay. There's an example of a transverse complete fracture. This is an oblique fracture. It's a complete fracture because it goes through both cortices, but now it's not straight parallel or perpendicular to the length of the bone. It goes at some oblique angle. Sometimes these are short oblique fractures like this one. Sometimes they'll start here, but they won't exit till down here. And those are long oblique fractures. Okay, so that's just an oblique fracture. Okay, here's an oblique fracture through this part of the tibia. Okay, that's a long oblique spiral-like fracture through that part of the bone as well. Okay, here's another long spiral fracture. He's also got a fracture here of the adjacent fibula and another one of the fibula there. Okay, comminuted fracture. This is a term you're going to use a lot. And this is a fracture that has multiple pieces. So here's a fracture piece here, here's a fracture piece here. Sometimes there can be 10 of these. So if it's a comminuted fracture, that means there's multiple pieces involved, not just two fracture fragments. There's at least 3 or more fracture fragments that leads to a comminuted fracture. Okay. Here's a comminuted fracture. Here's the proximal end of the femur. Here's the distal end of the femur, but now I got little fragments of bone here, one here, and little bitty ones here. So that is a moderately comminuted fracture. Okay. There's another comminuted fracture. This one, it's got one piece of the bone up in here. There's another piece of the bone here. There's looks like a mineralized fragment sitting right in here. They're overlapping here. There's another fracture extending through here. So another fracture extending through there. So he's got multiple fractures. It's a comminuted fracture, multiple pieces. There's a highly comminuted fracture. This is the proximal end of the scapula in this animal. I think it's a cat, but the proximal end of the scapula. So now we got multiple pieces of the scapula. The scapula is just all messed up and multiple fracture fragments involving that scapula. And what would you think? Do you think a fracture that is a complete oblique or transverse fracture in the mid-diaphyseal portion of the bone that's non-comminuted would heal faster, or do you think a fracture like this is going to heal faster? Obviously, intuitively, and you would be right, the comminuted fractures that have multiple bony fragments are usually going to take longer to heal than just a simple complete fracture. Okay, a multiple fracture is a fracture that is fractured in two separate parts of the bone. So now I have a short oblique fracture, complete fracture here in the proximal diaphyseal portion, but I have another transverse complete fracture in the distal diaphyseal portion of that bone. So that is multiple fractures of the same bone. Okay, this is an impaction or compression fracture. This is an example of a Salter-Harris type 5, where we have a fracture through the growth plate, but now we have grinding again of that growth plate, which will lead to cessation of growth of that bone and an angular limb deformity. An avulsion fracture. Okay, an avulsion fracture, this is the calcaneus. This is the top end or proximal aspect of the calcaneus called the tuber calcaneus, if you remember from anatomy. And there's a big tendon, a strong tendon that hooks onto that area. That's your gastrocnemius tendon. And sometimes if dogs have stress or trauma or whatever, they can actually, if they, instead of pulling the tendon and tearing the tendon stays attached to the bone, but pulls the bone off. Okay. And when a tendon pulls part of a bone off near its attachment, that has a special name, that's called an avulsion fracture. So that part of the bone has been avulsed from the remainder of the bone, and that you will only see an avulsion fracture at the attachment site of a tendon on a piece of bone where it actually yanks off part of the bone itself. Okay, a chip fracture you'll talk about, I think you did when you do large animal. Typically that is confined to horses and sometimes racing greyhounds in the carpus or tarsal region of a horse. A chip fracture it's usually a very small fracture that involves the articular surface of one portion of the carpal bones or tarsal bones. Okay, a slab fracture is also typically confined to horses and equines, where you have not just a little chip off the carpal bone or the tarsal bone, but it goes from one joint to another joint. You take a big slab off that carpal bone or tarsal bone. A pathologic fracture. What is a pathologic fracture? This is a fracture that happens to a bone, not due to trauma typically, but due to underlying diseased bone. So if you have a osteosarcoma or a severe infection of a part of the bone, and that bone becomes very weak because there's lots of lysis going on due to the tumor or the infection of the bone, sometimes a dog will fracture that just walking across the room. Okay, there's no trauma. The bone just breaks because something underlying in that bone is weak. Okay, so typically a pathologic fracture is one that's due to underlying pathology of the bone. Most of the time it's going to be due to infection or neoplasia. Okay, so here is an example of a pathologic fracture. There's an aggressive lesion with lysis, thinning of the cortex in that part of the distal radius of that bone, a moderate amount of soft tissue swelling around it, but it looks like it is also now fractured. So this would be an example of a dog that's got an osteosarcoma in there. He jumped off the couch. When he jumped off the couch, that bone fractured. Okay, that's a pathologic fracture due to some underlying pathology of the bone. Normally, if that bone was normal, that stress wouldn't have fractured. It takes very minimal stress to fracture a pathologic fracture. Okay, now the next subject we kind of talked about fractures and how you would characterize them. Now we have to haul off, and we're going to talk about how fractures heal. And I think this would be a good place to stop and continue tomorrow. Okay, so that's it. I'll give you 10 minutes back today. And, if you have any questions, obviously, I don't have office hours there because I don't have an office hour and because I'm not there. But if you do have any questions, email is the best way to reach me. Do you guys, I know your class rep has my email. So if you have questions or concerns or any issues like that, I'll be happy to try to address those. But the best way to contact me is email me. So it's your class rep has email. It's not hard. It's dr like Dr. Poteet at vitalreds.com. So if you got questions, let me know. Now your first test is not this week. It's the next week, right?
Right. Yes.
Okay. So we got time. Whew. So that's good. Okay. So questions, email me. Let me know if you got issues. Hopefully you're still enjoying the class and your fun meters are pegged out max right now. And we'll continue tomorrow at 9 o'clock in the morning talking about primary bone healing, how bones heal. All right.
Thank you.
Thank you. Bye.
Thank you.